You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoy the podcast, please listen, subscribe, like, and share it with friends. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcasts. And my guest today is Andrew P. Koutnik. He's a researcher studying the influence of nutrition and metabolism on health, disease, and performance at the University of South Florida, Morsani College of Medicine. He works with Dominic D'Agostino, a very highly esteemed researcher that is researching cancer and ketosis and many other aspects surrounding that. Andrew is currently writing his dissertation on cancer and cachexia, which is muscle wasting that occurs due to some cancers and in certain stages of certain cancers. Andrew originally began his research path at Florida State University in the exercise science area, studying the influence, again, of nutrition, exercise, supplementation, and environmental extremes on health-based outcomes in normal and clinical populations. From Florida State University, he transitioned to biomedical research within the Metabolic Medicine Lab, again at University of South Florida, Morsani College of Medicine, with a focus on studying metabolism and metabolic therapies for health, disease, and performance, and especially for cancer. Andrew himself is a type 1 diabetic for over 12 years, so he knows a lot about living with type 1, about the metabolic effects of type 1, and possibly how to mitigate them. So this conversation I have with him went so long, we had to divide it into two podcasts. This intro will serve as the intro for both podcasts. The first one is on cancer and cachexia, which again is his dissertation thesis. And the other one is about type 1 diabetes and type 2 diabetes, continuous glucose monitors, managing these conditions, and more. So Andrew is only 29 years old, but the amount of knowledge that this guy has, unbelievable. We probably could have talked for hours and hours more. We talked for 2.5 hours and then offline talked for another 30 minutes. So you're getting the top 2.5 hours of what we've spoken about. Again, each podcast is a bit over an hour. But this is, I remember Tim Ferriss referred to interviewing Dominic D'Agostino as a master class on cancer and ketosis. I would say this is of the same caliber, master class on type 1 diabetes and type 2 diabetes, and also a separate master class on cancer and cachexia and metabolic therapies. So listen in, and I'm really glad to have him.
All right. And then you mentioned type 1 diabetes. So if you have a bit of time, would you mind if we transition to discussing that for a bit?
Sure. Yeah.
Okay. Just for folks that don't know, how does it manifest? What is the disease involved? How is it different from type 2 diabetes?
So type 1 diabetes is a disease that you can describe as an autoimmune disease, where it is currently believed and that you have an inappropriate immune response that ends up targeting these specific cells in the pancreas that produce and or secrete insulin. They're called beta cells. Because the immune response targets them inappropriately, they see them as potentially foreign in the body, or something that should be targeted, kind of like if you had a bacterial infection or some type of response to a cold or the flu, your body builds an immunity to that, right? Well, same deal with building immunity towards or autoimmunity as well, where the body inappropriately views these cell types as something that should be, I guess, that the body should produce antibodies against and or attack. And that's called autoimmunity, and it's a maladaptive response, but that ultimately facilitates the destruction of these unique insulin-producing cells in the pancreas. And essentially, you start seeing this rapid decline in insulin production that ultimately can drive a patient, particularly with my disease, type 1 diabetes, to have progressive inability to automatically manage glucose levels by pancreatic, I guess, automaticity of the pancreas. So then that forces patients like myself to then inject insulin to make up for the deficiency in beta cell insulin producing beta cells that are no longer available. So in short, it's an autoimmune disease that ultimately results in patients having to manage insulin and glucose kinetics in their own body manually instead of what's done for most people automatically. How is that different from type 2 diabetes? Well, type 2 diabetes is generally described as insulin resistance, where you have the ability to produce insulin, but the body is resistant to the insulin that is present. So whereas type 2 could be seen as you have insulin secretion or production that does occur, type 1 diabetes is a reduction in insulin production altogether. So one is resistance, one is insulin deficiency, type 1 diabetes, and one is insulin resistance, which is type 2 diabetes.
Is there a scenario where you have a type 1B, I'm just making up that name, whereby you have type 2 and you ask the pancreas to produce so much insulin over so much time that it exhausts itself, or your pancreas loses its ability to produce insulin itself?
So that is, I guess, what is generally believed by the community. And this is, type 2 diabetes is not as much my expertise by any means. So I'll preface this by saying, this is my understanding of what other people who are experts describe it as, is that this type 2 diabetes is I guess, quote unquote, the stress upon the pancreas over a chronic period of time can actually cause the pancreatic function to slowly reduce. Its insulin producing capabilities and their effectiveness reduces over time, and then ultimately the reduced capabilities of not only production and release, but also the efficacy of that insulin does occur. So as far as I understand from people who are experts in this field, that is what you described is part of the scenario in type 2 diabetes as it becomes more progressive. But again, I'm speaking somewhat out of turn there on my capabilities. But that is my understanding.
Okay. So, you're in a unique situation, not a good one, but you're managing it well, it seems like. So what do type 1 diabetics do to manage their condition, and what are some of the ways that you found that made management a lot better?
Yeah, for most type 1 diabetics, unfortunately, glucose management, I guess, is generally believed in the literature based on what we see for outcomes in type 1 diabetics is generally to be a pipe dream. Like it's just not seen. Where the average hemoglobin A1C across many large population studies, and as a caveat to most people, anything I'm talking about here actually you can be found on a 3-part series I wrote on this, about 80 pages, about 200 or so references, describing this whole entire scenario, because I thought it was important to kind of dive into this issue in more detail, because I did a talk on this, and I felt like it was important to also complement that with much more detail describing the rationale, so people could look at that information and decide what I have to say, whether they believe it or don't, and look at the evidence for themselves, and at least be open-minded to considering that. But I literally made a website with just andrewkoutnik.com for the exact reason, just to put this information.
That's great.
Out there.
Okay, it's a great reference for listeners. Go ahead.
Yeah, so check that out if it interests you or not. But so a lot of the current strategies for type 1 diabetes management. So I guess I'll back up because I didn't really fully address this. Most type 1 diabetics currently, I would argue the average hemoglobin A1C, if you look at most large population studies where they quantify or assess hemoglobin A1C, is around 8. An 8 A1C, to give you perspective, normal is anything less than 5.6. And then 5.7 or 5.6 or less. 5.7 to 6.4 is prediabetes, and 6.5 or above is diabetes. Well, the average hemoglobin A1C in type 1 diabetics is 8%. And that's an average blood sugar of about 183 milligrams per deciliter. Now, it's not a direct conversion, it's an estimation. But that just gives you a perspective of normal is I generally believe to be 80 to 120. I know some people believe that the more you can keep that on the lower end of the 180 or 80 to 120, the quote unquote healthier that may be over the long haul, over someone's life. But that's kind of an open-ended topic, a different topic altogether. But type 1 diabetics are sitting on average at about 183. Now, the problem with that is that these hemoglobin A1Cs are a reflection of the average blood sugar over a period of time. So, and we also know that fluctuations in blood sugar can also slightly elevate hemoglobin A1C. So it is responsive to the flux in glucose. But when you look at the standard deviation in the mean blood glucose in type 1 diabetics, it's unbelievably high, meaning that you could have a high your average hemoglobin A1C of 183, but the standard deviation be like somewhere between 60 to 90 milligrams per deciliter. I mean, it just depends on what study you're looking at, but you could see it as high as 100, you could see it as low as 50, but the average is somewhere in that.
And you'd have so that means you'd have very high highs and very low lows, meaning you could have blood sugars of 250 and then other periods where it's 50.
I would argue that if you look at how most type 1 diabetics blood sugars currently look based on the literature, that most type 1 diabetics are flying all over the place with their blood sugar. That is what the literature shows. I can also tell you as a type 1 diabetic, that's not hard to accomplish either. It's if you do things I guess the traditional way, that's not uncommon. That's actually somewhat expected not only somewhat, it is expected for a type 1 diabetic to be dealing with that. I argue that doesn't have to be that way, but that is currently the standard for most type 1 diabetics. The current approaches, the current treatment strategies for most type 1 diabetics are things like carbohydrate counting, basal bolus protocols, intensive treated therapy, insulin pumps, continuous glucose monitors, closed loop systems. Man, there's other emergent things like islet cell transplants, these vaccines that people are interested in, stem cells. All these things are some of the current things that are either being investigated or being done. But the most common things currently done are carbohydrate counting. It's this idea that you eat like 15 grams of carbs and that's 1 unit of insulin. So a carb to IU unit or carbs to units of insulin ratio that you utilize. And then basal bolus is just this concept of you have multiple types of insulin. So most people don't maybe even appreciate this, but type 1 diabetics have to, that you actually have a subtle release of glucose that occurs throughout the day. And as a consequence, type 1 diabetics have to take something called a basal insulin, an insulin to cover the basal excretion of insulin or glucose that occurs throughout the day. Now, bolus, when I say basal bolus protocol, I talk about the basal portion of it. Those are things called Levemir or Lantus or these longer acting insulins that are more stable because longer release of insulin over a chronic period of time, somewhere upwards of 24 hours in some of these insulin types.
Oh, so if you don't address the basal amount, your glucose will drift up during the day from the time you wake until a point where it's, then if you eat a meal on top of it, it could really skyrocket. Is that the problem?
Oh, yeah, of course. I mean, actually, yes, there's really, you have to cover basal as a type 1 diabetic. Or at least, I'm not a clinician. I'm not telling anyone what to do with their medical management, so I'll get that out there up front. But most medical professionals would argue that is just not even a question mark. You have to cover the basal, or you're going to be chasing chronic elevations of glucose that happen all day long, because that's what occurs. Most people are gifted with a functional pancreas. Well, I guess maybe not most people, because we have this epidemic of type 2 diabetes that's occurring, but most people have at least a pancreas and at least beta cells present. And because most people have at least that, they have some automaticity to the basal glucose efflux that is going into the bloodstream that is causing elevations in blood sugar. But for a type 1 diabetic, because ultimately the end response is a very microscopic or absolutely depleted beta cell function, you have to cover that with basal level insulins. And so that's what's currently used for most people, or if they have as a side note, a pump, which constantly infuses insulin. These are different ways to cover that basal response. But the basal bolus is the bolus part of that is every time, as you mentioned, you have a meal, you would cover that with insulin. Now, traditionally, based on the kinetics of how some of these insulins should work and the carbohydrates for certain foods. So if I were to take a step back, so to kind of wrap that up in summary, you would bolus for the meals and you would take a basal for the glucose efflux that occurs over a 24-hour period. So if you didn't take insulin, the basal insulin, you would basically slowly go up all day. And if you didn't bolus for meals, you, of course, would have this really robust and quick elevation in blood sugar as a consequence of the meal. Of course, if you don't do either, you got a real problem. And that's actually what happens when patients actually end up in the hospital because they feel sick, lethargic, dehydrated, or throwing up. They're in ketoacidosis because they're insulin deficient. Their glucose is usually over 250 milligrams per deciliter, and their ketone levels, as a consequence of having no ability to shuttle nutrients out of the bloodstream into these cells that need nutrients, vastly upregulate ketogenesis to provide supplementary fuel. But in the absence of insulin, you cannot mitigate that gluconeogenic response. So you have this full-out attempt from the body to try and save the patient's energetic deficiency, but in doing so, there's no way to shut it off. And as a consequence, ketoacidosis results in super high glucose, super high ketones, and almost a replete or absence of insulin altogether.
So the common wisdom right now is eat what you want, but keep this ballpark value of 15 grams of carbs to 1 unit of insulin, and make sure you have enough insulin to counteract whatever you're eating, supposedly.
Correct. And that would be, that makes total sense though, right? So you have this rapid acting insulin. So we have all types of insulin now. We have long acting insulin. We have medium acting insulins. We have regular insulins. We have rapid. We have all types of insulins now. So you think, okay, we have basal insulin, what's called the basal gluconeogenic, or just the basal glucose efflux. And then you also have these meals. So let's just use a rapid acting insulin for these meals. That's the current paradigm. Most people do that. That's commonly recommended. However, if that actually worked, you would think that the blood sugars would be better, right? You'd have normal effective control of blood sugar levels across patients if those strategies were effective. But if you look at the literature, because basal bolus protocols and insulins for rapid and basal have been around for forever. So if those were effective, then you would think that these insulins would cover that. Well, they're not. I mean, they're not effectively doing that. So then the next question would be, what a patient just may not be actually effectively bolusing for the meal. Well, that might be possible, but it's unlikely that a patient who has type 1 diabetes, some are more flippant than others, some are super vigilant. Even the most vigilant of patients, I would argue, have far from perfect control, because I'm also speaking anecdotally here, but we know this across a number of just how the pharmacokinetics of these molecules work. If you have a carbohydrate-based meal, let's say right now, Andrew goes to, Subway down the street.
Right.
And he goes eats a sub, a 6-inch sub. I don't even know how many carbohydrates do. Let's just say like somewhere between 50 and 100, depending on what is put on it. And let's say, okay, Andrew, I need my carb to insulin ratio is 1 unit of insulin for every 15 grams of carbohydrates. Let's say that it's 60 grams of carbohydrates. I need 4 IUs of insulin. Okay, I'm going to take my rapid acting insulin before I eat, let's say 5 to 10 minutes. Or right when I eat, but let's say I did it 5 to 10 minutes before, because supposedly the time of onset from the injection is about 5 to 10 minutes prior to the meal. Then you eat your meal, and of course you just wait and expect your blood sugar to stay stable. Well, it doesn't. And the reason it doesn't is because when you inject insulin, okay, it depends on where you inject it, but you have to wait for the injection to actually be absorbed into the bloodstream first. So when you inject into the adipose tissue, it takes time for that insulin to make it into the bloodstream. But when it makes it into the bloodstream, then it's able to be distributed to the peripheral tissues. Insulin's glucose lowering effect is mostly as a consequence of skeletal muscle and adipose tissue uptake of insulin. Meaning, when I say uptake, I mean binding to the insulin receptor, causing these receptors called GLUT4 receptors to go to the surface and shuttle glucose into the cell to be stored and or used for energy. Now, that's the normal response. But you do not see. So that's why you have this glucose lowering effect, and that's why it's so important for the glucose to get from the injection site to circulation. But that takes time. It's not instantaneous. It's not rapid. It takes a period of time. Whereas a normal, healthy individual with a functional pancreas will actually see almost instantaneous glucose release. The reason being is because when we inject as type 1 diabetics or use a pump that goes through a cannula into the fat tissue, there's an absorption rate before it gets to circulation. Whereas a patient who has a functional pancreas, their beta cells actually have stored granules that will actually release into circulation almost instantaneously. So you actually see this really rapid response to the glucose elevating effect of food in normal healthy patients that's usually appropriate and sufficient to manage the blood sugar response.
Okay.
However, for a type 1 diabetic, so that could be within minutes. Let's say I ate, these Smarties candies that I use to elevate my blood sugar when I go hypoglycemic, because even through some of the best management strategies, you're not completely removing that risk. You're just potentially making management better. Whereas a normal healthy patient, the second the blood glucose rises, the beta cells that type 1 diabetics no longer, on average, have functionally, for the most part, they don't have the appropriate response, or you don't have that response at all. So you have to inject insulin to manage the glucose elevation. And that's the big discrepancy right there, is that while a normal response to glucose elevation is instantaneously from the beta cells releasing insulin and pre-packaged granulus directly in the bloodstream, a type 1 diabetic has to inject it, wait for it to be absorbed. And the difference between absorption of granulas that goes directly into the bloodstream, which is instantaneous, versus the injection is changing the kinetics of that insulin for hours. So if you would inject the most rapid of insulin, let's say I have insulin in front of me right now. I have something called Humalog. If I were to inject that into my adipose tissue right now, the general prescribed theory is that that's going to take about 5 to 15 minutes to start hitting my circulation, but then it will stay, it'll peak. The maximal insulin response will be at about an hour, and most of the effect will be gone within 2 hours. However, it's still in my circulation or still being absorbed into circulation over 2 hours. It doesn't take 2 hours for the glucose to be released from a Subway meal or even any meal for the most part, unless you just totally gorge yourself, and it takes hours to be absorbed. For the most part, most of these meals are going to be absorbed, at least the glucose of these meals are going to be absorbed rather quickly. I mean, I can tell you as a type 1 diabetic, if I don't bolus at all and know where to go eat something like that, most of the glucose elevating effect will be present within the first 30 minutes. So you have insulin that lasts for 2 hours, peaks at 1 hour, but then you have most of the carbohydrate-based meals, even if you were to try and use low glycemic options, take a very long time to actually, or take a rather rapid and elevating blood sugar, whereas the insulin takes hours to actually effectively do its job. So either you have, if you really want to truly control your glucose response to this, it's extremely difficult to do that with carbohydrate-based meals, only because the rapid-acting insulin almost never will be able to match the rapid nature of how fast the glucose elevation is as a consequence of the meal compared to how slow, comparatively, the insulin is at actually lowering the blood sugar in the circulation.
What about insulin pumps? Do they have like process controllers that continually observe the glucose level in a person and dish out insulin, or how do they work?
So those are things called closed loop systems, where you have a continuous glucose monitor that sits in your interstitial fluid, and then and I have to describe this first. So a pump is something where you inject a small little cannula that slowly releases insulin into the adipose tissue over the day, or if you say, okay, I have, let's say 0.5 or 0.25 IUs per hour of insulin injected every hour. And it slowly gives that every, let's say 5 or 10 or 15, 20 minutes, whatever it might be. And then say someone goes to eat Subway and they tell their pump to go give, let's say 4 units, as I told you, if it was 15 to 1 and it was 60 carbs. So that's a pump. So it basically just allows you to insert a cannula into adipose tissue and continuously release glucose into the adipose tissue cannula insertion spot. Then the other aspect of these loop systems that you're referring to is a continuous blood glucose monitor. Well, a continuous blood glucose monitor sits in the interstitial fluid. So you inject this cannula into your interstitial fluid. You then leave the cannula in. That cannula then attaches to a transmitter, which attaches to something like these devices called like Dexcom or Medtronic. There's Freestyle Libres. There's all sorts of continuous blood glucose monitors on the market right now. But how these continuous blood glucose monitors work is they enter the cannula. Those cannulas are coated with an enzyme. That enzyme is called glucose oxidase. When glucose is elevated in circulation, it will then diffuse into the interstitial fluid. As higher gradients of insulin are present in the circulation, it takes some time, but because there's a delay in what you actually see in the continuous blood glucose monitor for this reason, because what's in circulation takes some time to actually transmit or translate to the interstitial fluid. So, but when you have enough glucose in the circulation elevating, let's say that you're a type 1 diabetic and you ate that Subway meal and your blood sugar goes up to, let's say you had it controlled at 100 and you ate that meal and you didn't get any insulin at all. Well, you'll probably go up to 250 to 300. That'd be my guess for most people. If you're a small child, it'd be much higher than that. But for the most people, you're going up at least 100 milligrams per deciliter for most people. in most scenarios in a controlled situation. When that blood sugar elevates in the serum, because the body would digest that food in the stomach, then the metabolites from that food, protein or sugar, carbohydrate molecules, this turns into glucose ultimately, and protein to amino acids, and fat to lipid molecules. These all go, through hepatic circulation, then hit your circulation, or go through, then get filtered or processed by the liver, and then that, of course, ultimately ends up in circulation. Now, that ultimate end product in circulation, let's say you ate that, blood sugar elevates, that elevated blood sugar will slowly cause insulin to be absorbed into the interstitial fluid as it elevates in the serum. So it's kind of like this gradient thing where if you add more water, or let's say you add more molecules to the main, I guess it's kind of hard to describe other than saying if you had these 3 canisters, let's say that had this big a visual for people. If you had a tub or a fish tank, right? And in the center fish tank is the main fluid, and you have these filters that break the fish tank up into 3 compartments. So they're like little filters that are these really, really small holes that allow for whatever you put in the main compartment to then slowly, through a diffusion gradient, to go to these side compartments. So you put these filters from the main compartment to the side compartment of the fish tank. Let's say you dump a bunch of glucose into the main compartment. Well, it will take some time for the diffusion of that glucose, although in a fish tank example, it would happen pretty quickly. But in the blood glucose to interstitial fluid scenario, it takes time for that glucose as elevated in the main compartment to slowly diffuse into these side compartments. And one of the side compartments, so then one of the side compartments is the interstitial fluid, and these cannulas that have these glucose oxidase enzymes will pick up these elevations in the interstitial fluid. So it's downstream of glucose elevation in the blood. And the reaction of glucose oxidase with glucose produces something called D-glucono-1,5-lactone. But it also, as a byproduct of that, produces hydrogen peroxide. Hydrogen peroxide actually creates a signal that can be detected based on the sensor that's inserted. That sensor is then transmitted to a receiver that you're able to get a signal. Okay, so more glucose, more signal. Less glucose, less signal. You then use your blood glucose meter to then say, my blood sugar right now is 200 because I just had a Subway meal. And I'm getting this in your receiver, because I put in 200 into my receiver, which receives the signal from the transmitter, then that will tell the receiver what the ratio of signal to glucose level actually is, or an estimation of the ratio between the two. And you have a continuous blood glucose monitor that will then tell you what your estimated blood sugar is over a chronic period of time. And you give it continuous updates so it can stay as precise as possible. Now, go ahead.
Oh, so have you worn a CGM?
Yeah, I'm actually wearing one right now. I wear a Dexcom. I used to wear a Medtronic and switched over to Dexcom. I found it to be, at least at that time, more effective. But I will say that these things have become way more accurate than they ever used to be over a period of time. I find them to be very, very good at least getting delayed trends in blood sugar elevation. I guess they're best seen as blood sugar trend indicators. They're not necessarily exact because you obviously have to make a couple of assumptions to assume that whatever's happening in the blood automatically happens in the interstitial fluid, like that there is automatic diffusion of that glucose in the blood into these interstitial compartments. That's one assumption, which is generally true, but maybe not always happening ubiquitously just like that. And you also have to assume that the ratio you're getting from the two are equivalent. And you also have to assume that the enzyme is able to sufficiently cause a linear response to the amount of glucose to hydrogen peroxide produced. I mean, you have all these things that are assuming with these CGMs, but they've gotten pretty good at getting them accurate. At least I can speak from an anecdotal person who has to use these to try and manage their blood sugar levels on a regular basis.
Well, just so you know that I'm here with you, as I'm wearing one too, a Dexcom G6. So.
But I'm actually in the process of trying to get a G6. I have a G5 right now, which I definitely love. It has been amazing upgrade from what I was using previously. So I actually have to get, because of the whole insurance deal to get one, but I'm hoping to get one of those soon.
Okay. Well, if you don't mind, can I ask you some questions about I know that you're different than me. I'm not type 1, but I'm seeing some strange trends in it. So I wanted to ask if you have any insight into it. For instance, during sleep, I'll see that the glucose will fluctuate. So I wonder if there's any literature on glucose levels and stages of sleep.
So so there's actually, and I think this is where I gotta get into the whole personal thing about type 1 diabetes and how insightful it can be. I as a type 1 diabetic, you really learn a lot personally about your metabolism and how dynamic it truly is and what goes into actually changing it on a moment-by-moment basis over time. Most of what people think about metabolism is over the long haul. Are you overweight or are you skinny? Are you exercising or not exercising? Whereas type 1 diabetics can truly appreciate just how much in a day changes glucose flux and or insulin sensitivity to ultimately manifest in differences in insulin that you give or glucose insulin boluses you have to give throughout the day. Now, you had mentioned about oddities that might occur with sleep. Well, we do know while you're sleeping, at least in the periods of sleep, that there is typically a elevation in growth hormone in the sleep scenario. So that this is, I guess, typically associated with, and growth hormone is typically seen as antagonistic to insulin in I guess, some mechanistic ways. But growth hormone typically elevates. Well, there's some evidence to indicate that growth hormone can actually induce some level of normal insulin resistance that occurs. And that could, of course, elevate glucose during the sleep period. This is also in part why people discuss something called the Dom phenomenon, which is this known phenomenon that happens in some individuals, although many people would argue most individuals with type 1 diabetes, to experience an elevation in blood sugar upon rising. And part of that is in the later stages of sleep, there's this elevation in GH that would be antagonistic to the insulin response. But then upon waking, you have a cortisol response that occurs that can, of course, cause something called glycogenolysis, or the breakdown of glycogen stores, because it's seen as a stress hormone. And then you also might have an adrenal response to waking up. So there's a whole host of reasons that you might actually see a progressive a reduction in insulin's effectiveness, but also increase in glucose efflux into the circulation. That happens progressively from, let's say, middle of the night to upon waking.
Yeah, that's what I see is I'll see my glucose will be at one level, and right near the end of my sleep, it starts to rise. And then once I wake up, it rises a little bit more, and then it stabilizes.
Yes. And there's a lot of literature to describe why people currently believe that's happening. A lot of that is the GH response that they believe is causing an antagonistic response to insulin during those periods of time where GH is elevated. But also upon rising, you do have these cortisol responses upon rising, part of the wake period. But also some people believe there's an adrenal response as well to just the wake period. And what you're describing is kind of, so you said you do or don't have insulin resistance?
Oh, I do. Yeah. I've been overweight for many years, and I've been, improving my diet. So it's been getting better. I've had my insulin levels tested, but definitely still have it.
So in your scenario, the reason I even asked that is because in your scenario, it would probably be more observable than, let's say, I walk outside here and find a, 20-something med student who's exercising every single day and is normal weight. They may never see this if they were a CGM, whereas someone like yourself, who may be able to see some of these changes in blood sugar that are more impactful on your body, or someone like myself with type 1 diabetes, where just having a stable level of insulin, if there's a glucose efflux that occur, if I don't add insulin into that, well, of course, I'm going to be seeing the byproduct of physiology taking place, normal physiological responses that these diurnal variations in blood sugar, efflux into the serum, but also insulin sensitivity, there's a normal part of every day. I mean, a lot of what's taken for granted that a type 1 diabetic will have no choice but to have to deal with is, like illness. If you get sick, you can have these glucose elevations and or insulin resistance. The exercise increases insulin sensitivity. I think most people read about that and hear about the good effects of exercise, but the glucose sensitivity or the elevation in glucose effectiveness during exercise, then also there's something called contraction-induced GLUT4 translocation, or exercise-induced GLUT4 translocation. And there's a whole host of things that happen with exercise that changes sensitivity. Sleep quality. Let's say if I had to do a couple red eyes over the last 6 months, and those just totally destroy my normal insulin or glucose control. because it's a total stressor. Like, I can't sleep on planes to save my life. So I don't get the normal sleep, so I don't get that normal response that occurs. And then I have this, I can feel this like underlying discomfort, and I'm assuming probably an elevation in things like cortisol, though I'm making an assumption when I say that, that are probably driving, elevation in glucose into the serum. Things like caffeine, stress, hormonal fluctuations, just the time of day can change insulin sensitivity and or glucose efflux. That all go into managing on an everyday basis. And I guess I would argue that that's most salient in the type 1 diabetic.
Well, I could tell you some things I've noticed. So, last night I went to the movies, and I just, my weakness is popcorn. So I had some popcorn, and I went from 85 to 115.
Right.
And then I went for a walk because I don't like it up there, even though that's not that high. And then, I did some exercise, went for a walk, et cetera, and I got it down, it's 80. And then I stopped, and then it went down to, about 70, and then it rebounded back up to, to 90. But I've seen, for instance, that exercise pretty quickly can lower your glucose level. I'm not sure what's happening, in the background with the insulin levels now that the insulin's been released and all that. But, that's one thing I've noticed, for instance. Yeah,
there's an interesting study describing some of the changes that are revolving around GLUT4, insulin-induced effects on GLUT4 surrounding exercise, such as, your heart rate elevates, so the heart rate elevation means higher circulation or more circulation of these insulin molecules that can then have a better propensity to potentially bind to receptors. You also have insulin-independent GLUT4 upregulation that can occur absent of insulin, meaning that you can have GLUT4 translocation and then glucose uptake that can occur because of exercise. And some people believe that's because of contraction-induced effects in skeletal muscle. So there's definitely some reasons why there are good, there are changes in the effectiveness of insulin that occur with exercise. Certainly, I mean, that's a very explored topic in the literature for sure.
Well, I don't know if this will be advice, but if someone's experiencing high blood sugar, maybe something they could do to mitigate it very quickly, in addition to insulin if they have it, but is to, again, exercise or go for a walk to bring it down quicker than just letting it sit there at a high level.
And I would say, and that might be the case in a type 2 diabetic scenario. I know some type 1 diabetics who might use that for mitigating blood sugar elevation, but I would almost go to say that there are so many variables in a type 1 diabetic's life that influence insulin sensitivity. So let's say I'm in your same exact shoes. Let's say we both went to the movies together. You paid, of course, because I'm a grad student, I'm poor. And so you buy me popcorn. I eat the same amount of popcorn for you as you. And let's say that I'm like, okay, you know what? I think I need, let's say I ate what most people eat when they go to the movies, a whole bag. So let's say I don't even know how many carbs that would be. It's been so long since I calculated those things. But it's, let's just say 100 to 150 carbs. And let's just go 125. So at 125, let's say I do that 1 to 15 ratio. Let's just say 150 because that would be so much easier to do math-wise. So that's 10 units of insulin. I take 10 units of insulin and I go to 300. And then I start seeing myself slowly come down. But let's say you're like, hey, Andrew, my blood sugar went up to 100, it's not 124, you said?
115 or so, yeah.
Okay, 115. So let's say you're like, hey, Andrew, my blood sugar is going up to 115. I need to go outside and walk. You want to come with me? I'm like, okay, sure. I don't want to be an a-hole and say, you go walk on your own. So I go walking with you, right? And then my heart rate goes up. My absorption of the insulin from the spot of injection now increases. And now my blood sugar starts pummeling dramatically, meaning that whatever I gave at the period that I thought would be appropriate while I was rested, now I'm exercising, the potency of that insulin and the timing and the kinetics are expedited. So now I'm dealing with a whole new slew of confounding factors. What time of day is it? How much insulin did I already inject? How far out of the injection time am I? How much insulin do I think is actually left to be inducing a glucose reduction effect? And how long are we going to be walking? Because if I went outside and walked for 10, 15 minutes, no big deal. But let's say we pick the pace up and walk for 30 minutes to an hour. Well, that's totally going to transform the absorption and or insulin sensitivity effect. So now I'm dealing with like a whole host of dynamic factors to try and estimate what the effect will be. So in the type 2 diabetes scenario, that makes sense because you're just trying to make your body better at what it's doing. Whereas in the type 1 diabetes scenario, I'm dealing with the time of day. I'm dealing with the exercise. I'm dealing with the food. How far after the meal was it? Did I already absorb or digest all that food? How far out of the insulin injection? Where did I inject that insulin? Will it be faster or slower? How much faster would it be? How long will the exercise be that will then cause the glucose elevating effect to then be more or less potent? So in the type 1 diabetic scenario, there's so much to account for that goes on a regular basis. And it's often totally, I would argue, it's advocating for the type 1 diabetes community, totally underappreciated what they may go through on a regular basis. You know, a lot of type 1 diabetics, in order to manage their scenario, are really attempting to normalize their life into as consistent of a scenario as possible, at least the ones that I know. Because those who don't have a consistent life, and I can tell you, I am one who does not have a consistent life, it is so much harder to regulate your response to insulin because it changes throughout the day. And we know that these changes are occurring due to known physiological responses. It's not like, hey, you know, someone sprinkled fairy dust onto me and my insulin sensitivity changes. Like, there is known literature on why throughout the day there's diurnal variations in insulin sensitivity and glucose efflux. I mean, we know that these things happen throughout the day. It's just a type 1 diabetic has to then manage it all day. So it's a very oftentimes difficult thing to truly manage. And unfortunately, because to kind of circle back around to what we were talking about originally, the A1Cs of most type 1 diabetics are really sky high. I mean, 8% is the average. That means you have people above that and, of course, below that.
Wow.
And it fluctuations all over the place. You know, like I told you, you could have a 183 milligram per deciliter average, but you could have a standard deviations, you know, anywhere between 50 and 100. And so you can understand.
All right. So I can see how difficult it is to try to manage this condition. You know, it's so sophisticated and so incredibly difficult that, you know, especially on a standard diet or a high carb diet, I mean, it's almost impossible is what it sounds like.
It is. Well, if you're trying to, well, it depends what you mean by effectively managing it. And everyone's definition of that is definitely different. What I define as effectively managing it is getting your blood sugar between 80 and 120 for most of the day. So that is what I would argue is effectively managing it. Most people who are treating someone with type 1 diabetes or most type 1 diabetics, that's not how they define normal. You have to redefine normal, kind of like, you know, politicians may redefine what is like, you know, the tax brackets or whatever, you know, chronically. But, you know, I don't really pay too much attention to politics, but nonetheless, it's kind of like that. You just redefine what is normal. But if I were to define what is normal of 80 to 120, most individuals are eating a high carbohydrate based diet, and most people are failing to manage their blood sugar levels. Is there an association between that? You know, there's an argument. Someone may say, well, no, that's because of a whole host of other factors. Well, I would argue that's probably one of the largest contributors to the problem. You know, if you have if you have type 1 diabetes and the main problem you have is to regulate blood sugar levels, and this is my personal opinion, you know, take it for what it is and look into it for yourself and make your own opinions, whoever may be listening to this. So don't just take, you know, my opinion as, oh, there, Andrew said that, that's it. You know, no, look into this for yourself, see what other people have to say, and then come to your own conclusion on this. Don't just be sold on any one thing I have to say. Double check everything I have to say on this topic. I encourage everyone to do that. But if you have a disease of type 1 diabetes and you eat a mixed meal, let's say we go back to that Subway example or the popcorn example, that is going to cause elevation in blood sugar. You know, all the carbohydrates minus some carbohydrate forms such as fiber or, let's say, non-digestible forms of, you know, artificial sweeteners and stuff like that. But for the most part, most carbohydrates, doesn't matter if they're slow digesting or fast digesting, end up as glucose in the circulation. So that means that a type 1 diabetic has to then manage that with insulin. Unfortunately, managing that blood sugar elevation with carbohydrates with insulin, it almost never pharmacokinetically matches the glucose kinetics of the food they just ate, meaning that you're almost always going to be on a up and down scenario where if I took, let's say that 15 units was the exact dose I needed if I sat in the movies and took the 15 units right before I ate.
Right.
And that's exactly how much I needed. Well, do I inject that before I eat because the elevation will peak at 1 hour? Or do I take it right when I eat so that I'll have the elevation, but it will slowly be brought down over the 2 hour period? Well, it never will match. So you have to do what you can to, I guess, mitigate that. But nonetheless, the absorption rate of its effect lasting for the most part over a 2 hour period, and those carbohydrates getting in, usually mostly within the first 30 minutes, those don't match. I mean, those don't match at all. So it's not surprising that if you're putting more glucose into the system based on any type of meal, that it'll be exceedingly more difficult to manage that with any form of insulin that's currently available on the market. So how do you deal with that? Well, you can look at the literature and see the average blood sugar response and see how most people are dealing with it. They're just doing the best they can to manage it right now based on what is the current lifestyle of most people. However, probably the reason I'm even speaking to you today is because there are other ways to do that. And actually part of why I'm even in this PhD scenario is because of getting diagnosed. Well, it's a whole host of things. I was an overweight individual who lost a bunch of weight and was very empowered by that. I love exercise. I've seen everything that is done to I used to be upwards of like 250 pounds and mostly fat to dropping down to $170. And then I got type 1 diabetes. And then I now am about 220, been around 240, 250, somewhere around there. And I love exercise. I love what it can do to transform someone physically and mentally. But then I also, with type 1 diabetes diagnosis, grew to saliently appreciate what nutrition can do for an individual or can adversely do for an individual. It's I guess I would argue, no more pertinent example of that than type 1 diabetes. So if you're putting carbohydrates into the system and you have nothing to really manage that effectively based on kinetics, it's really hard to not deal with constant fluxes in glucose. And the results in the literature of type 1 diabetics reflect that. That's what we see in the literature. It's not like I'm saying, hey, this is what I think is happening. It's like, no, this is what the data says.
And what's the consequences of having, wildly fluctuating blood sugar levels? Essentially, what's the consequences of being a typical type 1 diabetic? What happens to these people?
So I usually describe that in two scenarios, the acute and the chronic. So the acute effects are, let's say that your average is 180. Well, you're hyperglycemic, right? So you're already above 120. You're hyperglycemic. There's a whole host of symptoms. You can Google hyperglycemia. There's a whole host of symptoms that accompany hyperglycemia. So most people are sitting in hyperglycemia all the time. So you have the symptoms of hyperglycememia all the time. And then you're trying to do what you can to mitigate these elevations in blood sugar, or just because of food, or maybe it's just because it's high and you injected insulin to bring it down. Then you have to deal with the flux of insulin. I can tell you the rapid decrease in insulin is something that definitely causes a unique physiological response. This is very anxiolytic. It's very anxiety provoking, because it's this really rapid reduction in glucose that has this very pertinent feeling associated with it. It's not so pleasant. And let's say you go hypoglycemic. Well, on the short end of things, the symptoms of hypoglycemia are reduced cognition, because, of course, you don't have as much glucose circulating to be able to have a functional brain. But then you also have the consequences of reduced capability. You have shaking, you have irritability, all these things that would typically accompany someone who may only have experienced this if they haven't eaten all day and they don't normally fast. So they might get minor hyperglycemia if they don't eat all day and they're used to eating 6 meals a day or 4 meals a day. And they may feel that, hey, I can eat like a horse. I'm so hungry. My brain is foggy. I'm irritable. That is minor hyperglycemia. A type 1 diabetic may experience twice the severity of a hyperglycemic moment within minutes, compared to someone experiencing that only after fasting for an entire day. So yeah, I can inject insulin right now. And if I wanted to, I am sitting in front of a fatal dose of insulin right now. I can inject 2 months insulin right now that would kill me. I mean, that's just reality. And you can look up in the news every year of a type 1 diabetic who, because of mismanagement, unfortunately, that's what happened. And it's terrible. I mean, it's terrible that this is a fear. And this is most commonly described in parents of children with type 1 diabetes, because you're somewhat unable to truly, you're battling two things. One, your desire to manage your kid's blood sugar level, because you know that you need to do that because you've been told it's not good to have high blood sugar or blood sugar mismanagement. And you have a child who probably doesn't want to be injected all day, be different than their peers, but they have a disease that is inevitably forcing them to be different than their peers. So you're a parent who's then trying to handle a child who has this unique but also very difficult disease to manage because it's all over the place in the blood sugar. I've talked to a lot of parents who have type 1 diabetes, and it's not, it is certainly a very, very difficult thing for them to manage. Very, very difficult for them to manage because there's so many factors that go into that. What if they go to school and
let's say they go to a friend's party or something, or they're in a social situation where they feel pressured?
Of course. Like, oh, okay, yes, of course. And let's say you don't want, you're that kid who's like, I don't want to pull out a syringe. Imagine the stigma associated with that. I can tell you the stigma associated with that. I've been in the gym multiple times, pulling out a syringe and injected it into my shoulder for a meal after I worked out. And this little kid walks by and sees me a syringe in my shoulder. And let me tell you, his face said everything you needed to see. There's so much stigma associated with needles and other things like that. So imagine a kid. This is what's nice about a pump for some kids is that it removes some of that social issues that some may have.
They probably think you're doing steroids in the gym too sometimes.
Of course. I mean, what would most people think if someone was injecting in the gym a needle? So there's issues and barriers for children to deal with, and a caregiver who most of the burden's now on their shoulders to do this, knowing and they're building the responsibility on themselves. It's extremely difficult. And these parents only want the best for their kids. These caregivers only want the best for who they're helping. I would say almost all of them, that's the scenario. So it's very, very difficult for them to deal with these situations, especially in children, where it's saliently difficult. But kind of coming back around to the difficulties of food, well, as a type 1 diabetic, if you have a disease of glucose mismanagement, it makes sense that if you wanted to try and have better management than is currently out there for most people are achieving with type 1 diabetes, then maybe having less input of things that will cause these fluctuations in the form of carbohydrates, which are the most potent elevator of glucose in the form of food, that maybe that might actually help. Maybe that might reduce the burden of this disease a little bit. Well, carbohydrates are not the only food that causes a blood sugar elevating effect. We know that protein does the same. In fact, there's a good paper illustrating that, if you consume protein, you have a glycogen response, a glucagon response that can then drive glycogenolysis, and you have a glucose elevating effect downstream of that. So protein can also elevate blood sugar, and then as a consequence in most healthy individuals, a more subtle insulin response. There was a paper in the 1970s that compared the glucose effect of carbohydrates versus protein, the exact response between the two, if you were to look at the area under the curve for insulin between protein and carbohydrates, is about, if insulin was 1, or let's say insulin was 100%, and that's our value, then protein would be 40%. So there's a 60% difference there between the carbohydrate-induced insulin response because of the glucose, of course, compared to the protein-induced insulin response because of the glucagon response. So it's about 60% lower, or if you're looking at it from the 40%, about 2.5 times higher. So protein obviously causes a much less glucose elevating effect. But what's unique about protein in the type 1 diabetic scenario is if you eat protein by itself or with fat, many protein sources, I guess you can get any type of protein nowadays. There's all types of options. But if you eat protein, there is a type of insulin called regular insulin that many individuals who are able to bolus regular insulin, because regular insulin takes about anywhere between 30 minutes to an hour and a half, depending on the person, to be absorbed. It peaks around the 2 to 2.5 hour mark. I hope I'm getting that correct, but I believe I am. And then it lasts for upwards of, 6-8 hours. Well, if you look at the kinetics of protein, you see a somewhat similar response. So a lot of people who inject a protein or protein and fat only meal actually are able to quite effectively match the kinetics of regular insulin to a protein or fat meal. This is what is at the heart of success of people who are actually able to get glycemic management with a low carbohydrate based diet, which we now have evidence in the literature for. When I first did this approach 13 years ago, I was diagnosed with type 1 diabetes 13 years ago. Actually, 12 years ago was when the first time I ever stumbled across a low carbohydrate diet. And I didn't even do it for blood sugar regulation reasons. I just did it because I thought at the time it might help my physique and or performance in the gym for a number of reasons. There was a lot that goes into that decision at that time. But I did it, and I changed my insulin with the help of someone who had more experience doing this approach than I did. And all of a sudden, 3 months later, I walked into my doctor's office, got blood work, and my hemoglobin A1C was 5.6 for the first time I ever did this. This was 12 years ago. You know, there was no how-to for me at that time. I just had someone who was a type 1 diabetic who I was familiar with, who was a bodybuilder who had experimented with all this. And I told this person I wanted to do this type of diet, and they had extreme knowledge on the kinetics of insulin, various types of insulins and foods. And they just kind of threw out pointers here or there on, okay, try this. And I grew an appreciation for the different kinetics of each type of insulin. And then, you know, with each protein-based meal, I would take regular insulin. I wasn't taking rapid-acting insulin anymore unless I had some type of carbohydrates with it. But at this time, I was doing this low-carb diet for the first time 12 years ago. And like I said, I walked into my doctor's office, and my doctor was like, that's incredible. You have a 5.6%. I've never seen that number in my office before. And of course, that was saliently, you know, I constantly use that word. I kind of like it, but it was so empowering to me at that time to have the ability to have a doctor of that stature, who was a very prominent doctor, at one point was the ADA president, one of the most incredible human beings I've ever met in my life. He used to call me every morning 3 months in a row to check on me. I mean, just amazing.
Wow, that's
amazing. Cool. Oh, he was an amazing human being and still is to this day. There's no doubt about it. And hearing that reinforcement was so incredible. And I was like, wow, there's something to this. I didn't even consider the blood sugar regulating effects. But wow, this is powerful. And I almost never found myself going low. I almost never found myself above 120. I was almost never below 80 and almost never above 120. And I'm like, well, this isn't normal. Like, this isn't what was happening before. And
is this with low carb, or was it a ketogenic diet, or what kind of macros were you having?
Yeah, the first time I ever did this, I would argue, is almost like the Atkins approach, where I didn't know what I was doing. But I just basically had as much protein as I wanted and as much fat as I wanted at every single meal. I was probably consuming anywhere from 200 and 250 grams of protein and 200 grams of fat in a day. And I was just having very low carbohydrate, really high protein, and really high fat, and bolusing that with just regular insulin throughout the day with a basal insulin at that time I was using mellitus, and it was amazing. Like, and at that time I didn't have a CGM. You know, I would just never see my numbers out of this normal range, and you know, I was sold because I felt better too. You know, without having these fluctuations all the time, I was like, wow, this is pretty amazing. I didn't expect this to happen I was just worried about how I was going to do in the gym. You know, at that point in my life, I was 17 going on 18. The only thing I cared about was how I looked.
Right.
So, but then I saw this byproduct of this eating strategy and this insulin strategy combined together. And I was like, this is incredible. And over the last 12 years, I tried a number of different nutritional strategies, mostly trying to figure out how effective or ineffective it would be for not only in the gym and performance, but also for my blood sugar management. And over that 12-year period, I have yet to find an approach as effective as this one is for glycemic management. And there are some that are particularly ineffective for glycemic management. But this one is one that is particularly effective. And now we have literature, before, there was a 2018 meta-analysis that came out. I think the author was Turton, Turton. I might be butchering that, but they did a meta-analysis on type 1 diabetes and low carbohydrate diets in 2018. I mean, we're talking mid last year, there was a discussion on this. And that meta-analysis, and for those who aren't familiar with the meta-analysis, it's a summary of studies. So basically you take all the studies on the topic, you have a selection criteria, and you then evaluate the selection criteria, the studies in the selection criteria based on, so you exclude certain studies, you include certain studies. But what they found in this study, I guess to summarize it, is that there was not enough evidence that a very low carbohydrate diet had any meaningful effect on glycemic control at all. And this was mid last year. But if you were to look at that study and micro dissect out the study, and this is again all on, I think this is on part 3 of on my website describing if you break down individual studies there. As a type 1 diabetic, you grow to appreciate that a certain amount of carbohydrate, keeping your carbohydrates as low as you can, typically the lower the better. Most people are around somewhere less than 50 grams per day. And that's in the form of fibrous carbohydrates, not in the form of, hey, I got my 50 grams of carbohydrates and Twix bars. It's because of it's the fiber that you want from that. And also it has a much less glycemic response, almost nil or null glycemic response. So you want that. You don't want just your 50 grams of carbs from rapid acting carbohydrates. That's not a benefit to this scenario. But
yeah, I can tell you, like, when I've had a meal that's, all protein and fat and almost no carbs, my blood sugar doesn't move at all. Be it like, let's say 85, and will just stay that way, which is really cool. And I don't eat so well. It moves. Yeah.
Well, congratulations to you. I mean, you that's something that it seems that at least it was like a acute scenario. And I guess there's also evidence in the type 2 diabetes scenario that can be a chronic management strategy for people. At least there's growing evidence for the long-term use of that, at least from groups like Berta Health who are publishing on that. There's people who've done this before previously as well besides Berta Health. But now so in that study, I guess, to finish up on that study, in the 2018 meta-analysis, they basically found that there was no consensus on the effectiveness or lack thereof of these diets. But yeah, in type 1 diabetes. Okay. Yeah, not in type 2, type 1. Because there's been a whole host of much less literature on type 1 diabetes in this diet than there is in type 2. There's been type 2 diabetes literature, I guess, for probably upwards of 30 years now, or more. People, I guess there's literature all the way back to like the Bernstein Approach and all that other stuff. But for type 1, there really hasn't been any literature on this topic. They're about, and I guess that meta-analysis, they looked at 8 studies they were able to include into their inclusion criteria. So that's nothing. I mean, when a meta-analysis, you're hoping to get like a ton of studies. They got 8. And those 8 studies had low carbohydrate defined in a whole host of different ways, which means carbohydrates as 40% or less of your kcals, 25 to, I guess, less than 25% by kcals, and then less than 50 grams per day. And those are the different criteria of what they call low carb, because in the literature community, low carbohydrate is defined in a whole host of ways. One way, the typical dietetics low carbohydrate definition is less than 45% by kcal carbohydrates, because that's low for most people. It's lower than most people consume, so they call that low. Whereas most people, I guess, in the ketogenic diet community, they don't really consider it very low or low unless it's less than 50 grams, because that's most of the literature that most people are studying in this field where there's been health promoting effects are seen. It's less than the 50 gram scenario, not less than 45% by kcal. So, and I can tell you as a type 1 diabetic, if I start having more carbohydrates than I need, we're talking more than 50 grams per day. And I just said, general number, everyone will be different. If I have more than that, then of course my blood sugar is going to be harder to control, because then I'm starting to have to manage this. I'm basically having to chronically fight a roller coaster. So the less chance I have of going on the roller coaster at all, the better at management. So I know that personally, that when you get above those grams of carbohydrates, things get difficult. So I looked at that meta-analysis, and I only looked at the studies that actually defined low carbohydrates less than 50 grams. And when you do that, you only find 12 subjects across 3 different studies. And in those studies, and those individuals, 2 of them were just a single diabetic in 2 different studies, and one of them, and in fact, I think one of those studies wasn't even in the meta-analysis, but there was essentially 12 subjects, and I show this on a little table, showing that if you had less than 50 grams, these people were able to actually effectively get normalized hemoglobin A1C of 5.5 or less. And that is so important, because if it's only 12 subjects, you can almost view that as 12 anecdotes. If you look at it from a research perspective, most trials have at least that number in an individual study. This is across 3 studies where you only have 12. So at best, this is scraping the bottom of the barrel of evidence for trying to understand whether this is or isn't effective for people using it. But then there was this paper came out in Pediatrics out of a group called Type 1 Grit. Anyone who's doing low carb and has Type 1 diabetes probably is familiar with this group. It's a group of low carbohydrate dieters. And it's an interesting story, because I had been doing this diet for 12 years on and off to manage my disease, and I only went off of it to try new things to see how effective it was. But always using this diet as a foundation to knowing this diet works. Like, this diet works for me. I will deviate off of it only to try other things to see how effective or ineffective they were. Always ended up back on this approach because nothing quite was as effective. But I had been doing this for 12 years, and essentially I'd never met another type 1 diabetic that ever had known of this approach up to that time. And then, I work with, in this lab here, USF Metabolic Therapeutics Lab, with Dominic D'Agostino, Angela Puff, a number of incredible people here. And they're out speaking about some of the work on cancer or wound healing or some other things. And they went to a conference, and I think it was low carb. Man, I forget where it was. It was in Denver somewhere, or I forget where it was. And they saw someone named Artie Dykman speaking. Well, Artie Dykman is the leader of Type 1 Grit. He has a son who has Type 1 diabetes, and he got onto this approach called the Bernstein Approach, which actually I went through and read that entire book. It's called Dr. Bernstein's Diabetic Solutions.
Yeah, I just got it. I'm making my way through it. It's good.
Amazing. Yes, awesome. I read through that as well, and I was kind of shocked because I had learned so much on my own just figuring this out by myself, and I found this book that damn near described the entire way of doing it, and just basically a how-to book. And I had been doing it on my own without any real guidance, and so I was like, wow, this is incredible. And he was describing this, and I got a text message actually from two people who were at that conference and said, hey, do you know about this group? And I was like, no, I haven't. And essentially I had never met another Type 1 diabetic my entire life up to that point who had done a low carbohydrate diet. And they're like, you should check it out. So I check it out and end up getting invited. It's a private group. You're only allowed in the group if you are a Type 1 diabetic, or they have a public group for anyone to see. There's a private group for only Type 1 diabetics or caregivers. And I got invited into the private group because I'm, Type 1 diabetic using this strategy. And I was blown away. There were little kids in this group, man, like 5, 6, 7 years old, with completely flatline blood sugar levels that were unbelievable. Wow. A1C. And then on top of that, not only flat blood sugar levels, which is completely uncommon in the pediatric population. The pediatric population, their average hemoglobin A1C is higher than the average for most people. So they're sitting even higher than the normal, for Type 1 diabetics, that is. And these kids were killing it. I mean, just knocking out of the park. And it really inspired me. Like, it really, really inspired me. And it encouraged me a lot. And there was this opportunity at University of South Florida to actually do a TEDx talk. And I said, you know what? I have done this for so long on my own. It was really hard as a scientist to get up and talk about a diet. And say this is effective management strategy because it was an anecdote. And as a scientist, you grow to appreciate that your anecdote, even if it's your own, may not work for other people. There are enough examples of that in science. You see it. I see it in my own experiments. It's something that I grew to appreciate as a scientist. So I was never really willing to speak out on this topic because I felt like I could be a one-offer. And I joined this group and I see kids and parents alike, or kids and adults alike, just nailing it out of the park in glycemic control, achieving glycemic control that less than 2% of all Type 1 diabetics achieve, achieving blood glucose stability less than 4% of all Type 1 diabetics achieve. I mean, it was literally unbelievable. And it just kind of blew me away. And I was like, there's opportunity came up to do a TED Talk and apply for it. And I applied for it at USF, ended up doing it. And around that same time, Harvard and Duke came out with a study looking at a survey study looking at the medical outcomes of the Type 1 Grit group. So because the word got out that the Type 1 Grit group was doing so well, achieving results that basically no Type 1 diabetics were achieving, Duke and Harvard got very interested to explore this group and wanted to evaluate them. So they did. They undertook with the help of Artie Dykman, people like Carrie Dulles, David Ludwig, Eric Westman, a whole host of individuals. I'm not even naming, Bernstein was a part of this. So there's a whole host of individuals who are part of this study who really helped put this together. And I'm certainly not naming everyone who did all this, but they essentially surveyed the group. I don't mean like, hey, this group went online and filled out a survey. They had doctor-confirmed data from these patients illustrating that these individuals, in fact, were achieving, on average, a 5.67% hemoglobin A1C, and inclusion criteria was only 3 months on the diet.
Oh, wow.
And yes, and that's, to put this in perspective, and this is what made me so much more empowered to even have a conversation with you here today. As a researcher, I'm always hesitant to do that, especially when it's something that just worked for me. Okay. But I know it's working for other people. And as a Type 1 diabetic, the current strategies out there, there is no effective management strategy right now. In 2000, there was a New England Journal of Medicine paper that came out that literally revolutionized the field because they did beta cell transplants back into patients, and they were able to normalize glycemic control within 3 months. Well, it was only in 7 patients. It was less than 10, but I believe it was 7. And they were able to get the average hemoglobin A1C into the normal range, less than 5.6, or less than 5.7, sorry. in that patient population. And it literally changed the entire field of type 1 diabetes research and hope that there might be a cure around the corner. That didn't happen, unfortunately, because a year later it was published that those beta cells that were injected in those patients were slowly dying off, meaning that the beta cells they injected were slowly having an autoimmune response. And they knew this was going to happen eventually because anytime you have beta cell transplants, you're on immunosuppressants. The reason you're on immunosuppressants is because it's expected that the immune system will attack those implanted cells, these donor beta cells or insulin cells. But just in 7 patients in the New England Journal of Medicine and back in 2000, probably the most cited paper in all of type 1 diabetes research, completely revolutionized the field. And here we have a paper in 2008, and there's nothing since then. And then, of course, those beta cells died off, and now they were stuck in a situation of trying to mitigate them dying, and nothing has worked for effectively managing type 1 diabetes. And then this paper comes out in 2000 in Pediatrics. The senior author was David Ludwig on this, and Leonard's from Boston Children's Harvard affiliate hospital was the first author on this, put together analysis of this type 1 diabetes group, type 1 GRIT. And this study showed in 300 patients, 42 or 46 of them, which were children, were able to have completely normal blood sugar on average. I mean, it was incredible. I mean, I cannot describe how important and impressive that is. It's actually the most cited or the most read paper in all of pediatrics for last year because of what it means to this potential disease state. And it also shows, and there's a whole host of utilities now that people are exploring low carbohydrate diets for diseases, health, performance reasons, whatever they may be. But I'm particularly interested in type 1 diabetes, obviously, for my own personal reasons. And this paper is a total game changer for that and illustrated that it's possible. I'm not saying that every type 1 diabetic who goes change over to low carb, that's the end all be all. There's obviously a lot more that goes into it than just changing over to low carb. It's changing over the foods that cause the blood sugar spikes that are very difficult to manage with any current insulin strategy, and just using the foods that are manageable with current insulin strategies available right now. And then simultaneously managing with appropriate insulin strategy as mentioned, but also fitting your lifestyle around managing it. And that's what these people did. I mean, they're a very motivated group of people. I know because I'm a part of that group, and I can definitely attest to the motivation of these individuals. They are diehards about trying to get it right. And most of these people are largely motivated by trying to reduce the complications and risk that are so salient in this disease. You asked me before, what are the complications of this? And we got a little derailed. But the acute complications of the hyper and hyperglycemia that happen every day for most type 1 diabetics, especially hyper, because most avoid hypos altogether if they can, but often aren't able to completely. But then there's the chronic problems. The chronic problems are what is motivating to a lot of people in this group, because I outlined this in the write-up in part 2 of the write-up online, but you often don't hear about all these complications. I was actually quite upset when I started reading about this when I was actually in this PhD program, more aware of the literature on this topic in type 1 diabetes. I was actually kind of angered because I was never told about half of these things, and maybe that was for the better because there was no strategy to really get over it or to overcome them.
Okay.
But you're essentially set up for increased risk on average if you get average results for type 1 diabetes for all 10 of the leading causes of death. All 10 of them. So diabetes is one of the leading causes of death. You have increased risk for all the other ones as well. It is a really difficult disease. Now, you're in increased risk for all these other diseases, but there's also side things that aren't mentioned. Children with glycemic risk management have changes in brain function, changes in cognition that occur at young ages like that. Another example of some of the tragedy that happens with this is over 80% of type 1 diabetics within 2 decades of diagnosis will have retinopathy. And it's pretty terrible. But there's been about 3 papers that have looked at what the real consequence of all this is, and that's mortality. And on average, a type 1 diabetic is expected to live over a decade shorter than their non-diabetic peers. Meaning that I'm Andrew Koutnik, I am 29 years old, and I am expected as a type 1 diabetic to not live into my 70s, but at my best live into my 60s with type 1 diabetes. And keep in mind, that's the average. we're also talking about people who will live much shorter because maybe they have glycemic mismanagement that drives them into adverse control.
Right.
And ultimately, that's the average reduction in survival in patients with this disease. And it wasn't one study to show this. There was another study that came out last year in Lancet showing that if the earlier you're diagnosed with type 1 diabetes, the more increased your risk is. Females have it even worse. Their reduced survival is slightly higher than males. And there was even numbers on the order of if you're diagnosed early in age and have glycemic, if you're a type 1 diabetic and you're a part of the cohort that was diagnosed at its earliest, man, your increased risk for things like cardiovascular disease are exponentially higher, unbelievably higher.
It's shortened lifespan and dramatically shortened health span too.
Correct. And both those combined really lead to, and then you ask the question, well, then what underlies all these problems? Well, at its core, glycemic mismanagement is driving most of these problems. And if anyone sees it differently, I would love to, I would love for them to reach out to me and discuss this with me because I'm very open-minded. I myself am a type 1 diabetic as well. I also want to find the best strategy. I am no fan of any one diet at all. I'm a fan of what works. And what appears to be the most effective strategy for reducing the risk and complications, not only acutely, but chronically in type 1 diabetics, all gets back to, based on what we currently know about type 1 diabetes, is glycemic control. So if type 1 diabetics can achieve better glycemic control, in theory, they would be reducing the risk. Not in theory, acutely. Acutely, you're definitely reducing the acute complications. But chronically, in theory, you're reducing all the risk factors. In fact, the top 2 risk factors for type 1 diabetics, based on a 2016 ADA publication, the first one is hemoglobin A1C, and the second one are triglycerides. Well, if you do this diet effectively, and you're one of the people in the type 1 group who are able to manage it exceptionally well, you're reducing the primary risk factor for cardiovascular disease, one of the biggest problems in this disease state, one of the things that can induce death early for many type 1 diabetics. And then secondary is triglycerides. Well, one of the most common metabolic consequences of a low carbohydrate diet is reduced triglycerides. So you're reducing the assumption that this diet is helping type 1 diabetics is largely based on everything we know about the physiology of the disease, how it manifests, and how it progresses to cause adverse outcomes. And that's around glycemic mismanagement. And a diet like this has been shown to effectively manage, of course, match with the right insulin, match with the right lifestyle. And a large cohort of patients showed that it was possible. I'm also living evidence of that as well, that it is possible. But I'm an N of 1, and as a scientist, as I said, I don't buy all in on N of 1s. But there's an entire group of individuals I see every day thriving off this approach. And it's hard not to at least put it out there that this is something that, go ahead.
Yeah, just like your resistance to N of 1 experiments, it seems like the medical community in general is resistant to non-drug interventions, period.
To some degree, to some degree. And I think most people, and this is something where I kind of, because I've had some pretty incredible doctors, and a lot of people harp on the ADA and give them a really hard time, but my doctor was the ADA president. Man, he was one of the best doctors. He's actually the best doctor I've ever had. So there is certainly some of that is occurring for sure. I don't want to downplay that at all. But I also want to illustrate that no one gets into this to try and hurt patients. They get into it because they're trying to help patients. I don't think any doctor went to medical school saying, I can't wait to screw over this, patient X or Y. They went into it, I'm sure, because they at least in part wanted to help someone have better health. So it's just, unfortunately, the tools currently given aren't doing that. And there are a number of concerns in the medical community, especially from providers, about the adverse outcomes of a disease like that. And that's part and why I actually went into quite extensive detail to try and outline what those arguments are. Some of the concerns are ketoacidosis, hyperglycemia, pediatric growth, cholesterol, long-term health. Doctors feel like there's compliance issues with the diets, that may reduce quality of life. And then there's people who are concerned about protein and kidney health. And I argue that if you view at this disease in its entirety, the 30,000-foot view of what people are concerned about with this disease versus what it actually provides, I argue that it's overwhelmingly in favor of the hopes of what this diet may provide. If you dive into this, I don't even know if you have time for this, but I can address every single one of those concerns currently out there in the medical community that are currently rising. So some of the common concerns right now in the medical community that I've heard of or heard from patients who have heard from doctors who are concerned about doing this approach. Well, the first thing that pops up is ketoacidosis. If you're doing a diet like a low carbohydrate diet, would that not elevate ketones higher and then put people at risk for ketoacidosis? Well, risk for ketoacidosis is associated with actually increased hemoglobin A1C. So the higher the hemoglobin A1C, the higher the risk for actually getting into ketoacidosis. And this is, of course, associated with glycemic mismanagement. But if you're able to actually effectively manage your glycemic control, but also your hemoglobin A1C, you're vastly reducing the incidence and risk based on the risk factors for ketoacidosis. Additionally, it's a very common healthy response for, and anyone in the endocrinologist community will appreciate this, fasting and or carbohydrate restriction. A normal healthy response to that is a slight elevation or modest elevation in ketone bodies. That's normal. Ketone bodies get a bad rap in type 1 diabetes specifically, and got a bad rap in the health community as a whole from type 1 diabetes, where you see pathological levels of it. But that's typically over 10 millimolar when a type 1 diabetic goes into diabetic ketoacidosis. It's nowhere near the same thing as a normal, healthy ketone level of quote-unquote nutritional ketosis, and some people would put that around 0.5 or 3 millimolar. It would depend on the person, right?
Yeah, I was going to say people are happy to be one millimolar. Forget about 10.
Right. So, and that's the normal range. And we also have an emergence of evidence as to the health promoting effects of these molecules that have arisen. So, in many ways, we have as a community, at least in this community I'm familiar with, have reevaluated ketoacidosis or ketones as a bad thing. But in the type 1 diabetes scenario, ketoacidosis in theory would be reduced because you're actually having better glycemic control and your risk of having ketoacidosis events, which I would argue nutritional ketosis is normal homeostatic glucose, moderate to low ketones, and low to moderate insulin, a sufficient amount of insulin to manage ketone levels. Whereas ketoacidosis is over 250 milligrams per deciliter glucose, over 10 millimolar ketones, and extremely low, insufficient insulin. It's a completely different physiological scenario. So that's the first one. Okay. The second one is hyperglycemic risk. So there's the idea that if you have A1Cs that are lower, that you're at increased risk for running hypoglycemic. Now, there's good reason for that because there was a huge study conducted called the DCCT and EDIC trial, which actually looked at patients doing intensive insulin management. But they called it intensive then. It's quite normal now, where patients used to only inject about 2 times per day in insulin, type 1 diabetics, which is nowhere near going to effectively manage glycemic control. And then they also said, well, we need to also, we want to compare that to 3 or more injections a day and see if we could reduce the complications of this disease. And what they found is, yes, in fact, they were able to reduce the complications of this disease. But the problem is that more people got hypoglycemia as a consequence. And that makes sense because you're injecting insulin, you're more intensively managing it, you're more likely to run low if you're chronically trying to chase normal blood sugar levels when it's almost impossible to do that based on the kinetics of the food most people eat and the insulin kinetics.
Yeah, if you're fluctuating, right, tremendously, and your your A1C is lower, that means it's still fluctuating a lot, but just around a lower set point.
Right. So, correct. There you go. You nailed it. So, and again, this is another marker that runs simultaneously in risk with hemoglobin A1C. So the higher the hemoglobin A1C, the higher the risk for hyperglycemia. And of course, this gets back to your point about blood sugar standard deviation, which both of those things, hemoglobin A1C and blood glucose standard deviation, are things that we know decrease on an approach like this if done effectively. So both of these primary risk factors for hyperglycemia are also reduced. And if you look in the type 1 grit community, one of the things they're actually doing a low carbohydrate diet for, in fact, Bernstein actually claims part of the reason he claims to have done the low carbohydrate diet is to reduce the incidence of hyperglycemia that he was observing. And I can attest to the fact that you dramatically reduce the incidence in myself of hyperglycemia, but also the severity of them because you're not diving off, the edge of a cliff in blood sugar levels. If you're going low, it's because it's subtle, lowering of blood sugar. So that's that kind of the second one. First one, ketoacidosis. Second one, hyperglycemic risk. The third one is just quite apparent, especially in doctors who treat children, is pediatric growth. There's studies in seizure patients showing out of Johns Hopkins, actually, Newman, and I've actually talked to Eric Kosov out of Johns Hopkins about some of these studies, and because of the context of type 1 diabetes and people's concerns, there's been evidence in the seizure community that if you do a strict ketogenic diet, you can impair pediatric growth. And it's important to mention that a lot of the diet that most people, especially the type 1 grit community, are doing is a diet that's not low in protein. In fact, it's at the very least sufficient amounts of protein. It's very different from the 4-to-1 ketogenic diet. And one thing that is often not discussed is that pediatric growth, we know, pediatric growth impairment is associated with glycemic mismanagement. So, and yes, right. So in theory, if you improve glycemic control, you reduce the risk associated with pediatric growth impairment. And if you have a diet sufficient in protein, in theory, you may not have the same consequences of impaired growth that some of these diets did in seizure patients. Well, if you look at the pediatric population, I talked to Dr. Leonards about this, not all the pediatric patients had reported growth, but the ones that she had indicated they did not have impaired growth. And if you look at some of the other studies in the literature that show that there are risks for impaired growth, you almost always see a poorly implemented ketogenic diet or low carbohydrate diet with a co-administered scenario of caloric restriction. And we know caloric restriction impairs growth.
Right.
So combined, we just don't have evidence for that in the type 1 diabetes community. In fact, in the type 1 grit paper, we actually see that the growth impairment isn't present in the children doing the diet for those who reported growth. So that's the third thing. So you have ketoacidosis is 1, hyperglycemia is 2, pediatric growth is 3. The third one is cholesterol and long-term health. And I kind of addressed this earlier in that the risk of the idea is that if you have a high-fat diet, of course, you're going to run the risk of having elevated cholesterol, and LDL cholesterol is associated with, some people believe it's causal, although the evidence isn't there that it's causal, but there's people who believe that there's enough evidence to indicate that LDL cholesterol is causal in cardiovascular disease. So if you eat a diet that's super high in fat, you're running the risk of, having patients who are already at risk for cardiovascular disease exacerbating that. Again, getting back to that 2016 paper for what actually is the highest risk factors in type 1 diabetics for cholesterol in cardiovascular disease, hemoglobin A1C and triglycerides are number 1 and 2. And these are both things that we know reduce on this diet rather remarkably. On top of that, we also know there's evidence that this diet, if done effectively, elevates HDL cholesterol. And we also know that, at least for macrovascular diseases, elevated insulin seems to be associated with macrovascular diseases. So reducing insulin load is something we know is a hallmark consequence of going on a low carbohydrate diet in type 1 diabetics. In fact, my insulin requirements now compared to being on a standard diet are about 70% lower. And I will also go to say that that's not entirely uncommon from other patients to describe. In fact, there's literature outside of type 1 diabetics showing 50 and 66% reductions in insulin load in different scenarios. So all these factors combined, the primary risk factors associated with these worry of cholesterol driving long-term adverse health outcomes in the context of cardiovascular disease isn't keeping in perspective that the primary risk factors are actually improved dramatically with this approach. And that has to be kept in mind. It's not that it isn't a concern. It's just you need to keep in mind where's the primary problems. And this is something that addresses the primary issues. Now, the last two things are, the first of the last two things is compliance and quality of life. We know that doing any diet, and I guess the concern is, okay, if you do a low carbohydrate diet, it's restrictive. You walk in the grocery store, you're walking away from the center of the grocery store basically entirely, because that's mostly carbohydrates.
Right.
And so patients are going to comply to that. There's no way they're going to do that long term. Well, there's evidence that that's true. Yeah, that is true. Patients have reduced compliance on a low carbohydrate diet. But the reduced compliance is no different in a low carbohydrate diet as it is from an Ornish diet or any of these other style of diets that people are implementing. It's the same. The reduced compliance is the same no matter what diet you're trying to complete. The compliance issue is not unique to this diet. It's the same for all diets. Now, there's an issue with, okay, well, I don't have as many food options, but we know that because of the expanding interest in this low carbohydrate sphere, that there's a whole host of readily available package-based foods that people can buy and currently eat. And I do find this diet as something that I actually currently do enjoy because most of the foods I do enjoy are part of this diet, especially on the meat and eggs and fish realm. But the last thing
is a pretty delicious diet, actually. You can eat a lot of great stuff.
Yeah, and I would argue, I'm super biased on that, so keep that in mind. But I agree. I do enjoy it. I find a lot of people also do enjoy it as well. I'm sure some people won't, but there's always some who will and won't. The last thing, though, that I think is important to always consider is we know glycemic mismanagement can impair quality of life. We know that living a life where you're constantly running roller coaster is going to impede your ability to live the most fulfilling life. And I can tell you that is absolutely true in my life. But if you're able to have a scenario where you actually are able to acutely control your glycemic control, and that translates into feeling empowered over a disease that you felt completely crippled by, that I would argue might improve compliance long term, because you don't have a choice in type 1 diabetes. If you have it, you have it. You have to deal with it. If you can find something that helps you manage that, that's something that I would argue would never hurt your glycemic control, or it would likely not hurt your compliance. If anything, would drive compliance.
Well, yeah, that's what I was going to say is, many drugs have side effects, which would make it hard to comply with taking them, especially if they're really intense. But if you have something like a ketogenic diet that makes you feel better and is not so hard to be on, it would drive compliance. I would be like, I feel better doing this. I want to keep doing it.
Yeah, no, and I'm not here to tell you that it's like the easiest thing ever. Like, you are walking away from certain foods. It does take an educational process from the patient and the physician on how to do this. It's not, there's no give me, and there's no freebies in this, right? It takes real effort. But damn near anything in life worth having does take real effort. And if you're dealing with a disease where the acute complications in a day of fluctuating around, running hyperglycemic for most of your life, and having those salient, really powerful hyperglycemic moments is something that we know impairs quality of life. So if you can dramatically reduce all of that, I think that it's something that might translate over to compliance. And we know that in the pediatric paper, of course, it's very biased because these people are highly motivated to be on the diet. I think it was 87% of the people enjoyed the diet. So that might have a lot to do with the fact that they were getting good control, and as a result, enjoy the diet. I actually personally choose to do the diet because it improves my quality of life dramatically for that exact reason. If I eat a carbohydrate meal right now, I'm like, oh man, someone had a birthday party and they had this or that. And of course you can make alternatives. You can go to Caroline's Keto Kitchen, and there's all sorts of alternatives you can make that have similar flavor. Some don't all, but for the most part, you can make pizza, you can make donuts, you can make bread, you can make all these things as well if you wanted to eat them in low carbohydrate and be able to manage it with this eating strategy. But if you were to, let's say I were to walk next door and they had a birthday party for someone and they had cake. Well, I'm choosing not to eat that cake because I know what's going to happen for the rest of the day. It ain't going to be worth it. I will be running hyperglycemic, and the consequences of that hyperglycemia and glycemic mismanagement will continue and persist for the entirety of that day if I'm not able to correct it almost instantly. So that's something that has to always be kept in mind when someone says, well, you won't be able to stick with that long term. But they may not realize what a type 1 diabetic patient is actually dealing with when they don't have a strategy that effectively manages their glycemic control. The last thing, that's the second to the last thing. But the very last thing is the concern of protein and kidney health. And there's concern that, protein will cause kidney damage in patients who are already at increased risk for renal failure, or not renal failure, retinopathy. And no, it's not retinopathy, but kidney damage. Okay, so kidney damage is not uncommon to progress because of these small, very, susceptible vasculature in the kidney that filter out nutrients and minerals and other things like that. It's highly susceptible to damage due to hyperglycemia, and we know that. And people are worried, okay, well, if you have patients who are at risk for damage having elevated blood sugar damage in the kidneys, having a high protein diet, wouldn't that exacerbate it? Well, that whole ideology came out of a hypothesis paper back in the 1970s or 80s, describing the hypothesis that in patients who have renal failure, that if you have elevated protein, you have breakdown of protein into urea, and urea, of course, being secreted from the kidneys, or at least a eventual breakdown of protein will end up in the urine. And wouldn't that stress the kidneys out more? And that kind of perpetuated as low protein diets are able to help extend life at least a little bit in patients, in some studies, not all, in patients with kidney failure. But there was a recent meta-analysis conducted by Stu Phillips and others showing that elevated protein diet is not associated with kidney dysfunction. And that they argue that a lot of the hypothesis surrounding high protein diets causing kidney dysfunction is largely driven based on just values where people just look across populations and not necessarily change values pre and post high protein diets. And in their study, they were not able to find any association with elevated protein and changes in kidney function over time. And, protein is also an important part of a healthy diet. We know that getting all the amino acids is important, and it may arguably could be optimal for things like growth and having a healthy diet. We know that protein is important for maintaining skeletal muscle mass. There's no doubt about that. When I talk about ketone bodies and their potential anti-catabolic effects and pro-synthetic effects in certain contexts, protein we know has many of those same effects, if not more powerfully so in some scenarios, depending on the context. It just depends, and they haven't been directly compared, so that'll be an interesting thing to study in the future. But we know protein is very important for maintaining normal, healthy skeletal muscle. And we know that that's really important for overall health. So when we keep all this in perspective, and those who are concerned about this diet, I understand those concerns. They do make sense. It makes sense to be concerned about a diet that's kind of seems new, not necessarily recommended by a lot of people in the medical community.
Right.
And there's concerns of ketoacidosis, hyperglycemia, pediatric growth, cholesterol and long-term health, compliance and quality of life, and protein and kidney health. But if you look at the overall picture of a type 1 diabetics scenario and what would potentially help all of those, I would argue that there's so much hope to be gleaned from a very low carbohydrate diet if you have type 1 diabetes. And I'm not here to tell anyone what to do. Of course, I'm just here to espouse a possibility that might be available for someone trying to get a better overall quality of health and maybe a result in longer health.
Yeah,
I think I'm here to advocate for it.
No, that's great. There's been you have a ton of knowledge. I think anyone listening to this podcast that has gotten to this point is definitely open to to dietary intervention versus the what their situation is right now. So yeah, I don't think you have to worry too much about that. But I appreciate you relating your experience and all your knowledge. This has been like a tour de force.
I truly appreciate the opportunity to come on and speak about a number of topics that I am honestly very, very passionate about. I always tell people when they ask me, what should I do about, what do you think about this career path or this career path? All I tell people is do what you love. I'm an example of someone who got the opportunity to do exactly that. And let me tell you, I would pay all the money I currently have in every savings account, investment, everything to be able to do what I'm doing right now. And I'm very honored to have the opportunity to even speak about it. So I appreciate you for that as well.
That's great. Well, Andrew, thanks so much for coming. I really appreciate it.
Absolutely, Richard. I appreciate it.
You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and share it with friends. Thank you.